الصوت شغال ها؟
شغال.
اي الصوت شغال.
عندنا قرابة ال 400 شخص طلب المشاركة.
ما فيش مشكله، احنا ننتظر. انا شايف العدد بيزيد فندي برضو فرصه،
استنى شوية.
لان على فكره تو جوين بياخد وقت. تو ريجستر لازم اسمه وسنه وعنوانه وتاريخ ميلاده واقامته وجاي منين ورايح فين، يعني حاجات كتيره برشا
برشا
كتيره
هاك حاضر
برشا يعني a lot of
برشا لغة تونسية.
اما انا بحاول اني بحكي يعني لغه تونسيه وبحكي كويس عشان لما نيجي عندكم ان شاء الله نشوف الاكل الجميل التونسي والشوربه الجميله. انا فاكر دايما بخير ودايما بصحه ان شاء الله.
عمل الكسكسي التونسي.
الكسكسي التونسي جميل خالص. احنا يعني كده بتخلونا يعني نجهز ان شاء الله يكون فرصه جميله وبدايه جميله، وشكرا لكم خالص كتير برشا، وشكرا كتير لكم برشا.
مرحبا بك بروفيسور.
اهلا بكم.
نحب نبداو دكتور شرف الدين؟ نستنى شويه.
في اي لحظه احنا جاهزين. اول ما تلاقوا الزملاء العدد المعقول وصل معانا، بس هي فعلا موضوع الريجستريشن بياخد وقت كتير عشان
زي ما حلينا.
طيب
الصوت.
ميكرو دكتور شرف الدين، ما نسمعش فيك.
يس.
ميكرو. سي.
زملائي زميلاتي الأعزاء، عسلامة، مرحبا بجميع الحضور معنا من تونس ومن خارج تونس في هذا اللقاء اللي تنظمه جمعية أطباء الأنف والحنجرة والأذنين وجراحة الوجه والفك بالجنوب التونسي لامامس. اسمحوا لي في البداية باش نقدم نفسي ونقدم الجمعية ونشاطاتها. أنا دكتورة ريهام شرف الدين، أستاذة في كلية طب بصفاقس، رئيسة قسم الأنف والحنجرة والأذنين بالمستشفى الجامعي لحبيب بورقيبة بصفاقس، ورئيسة الجمعية. هكا باختصار، صفاقس هي مدينة، هي أكبر ثاني مدينة بعد العاصمة، موجودة ما بين الوسط والجنوب التونسي. بالنسبة للجمعية، جمعية مامس هي جمعية قديمة شوية، تكونت سنة 1995، والجمعية هذه من اللي تكونت منذ تكوينها تقوم بتنظيم دورات واجتماعات طبية في الاختصاص بصفة منتظمة بمعدل ست اجتماعات في السنة. وفي زمن الكوفيد، وقت الكوفيد، قمنا بالعديد من تنظيم العديد من الملتقيات عن بعد، وبهذه الطريقة سمحت لنا معناتها باش نستفيدوا من خبرات عالمية في مختلف مجالات اختصاصنا، وباش نربطوا العديد من العلاقات جديدة مع أصدقاء جدد من مختلف البلدان العربية والأجنبية. واليوم وفي هذا الإطار تشرفنا كثيرا بحضور البروفيسور الدكتور رضا كمال من شقيقة مصر. الدكتور رضا مشهور جدا، طبيب بروفيسور متضلع في أمراض وجراحة الأنف والجيوب الأنفية معناتها بمصر. سعداء برشا بحضورك دكتور، شرفتنا برشا. سعداء ايضا وتشرفنا بحضور كل الزملاء من مصر، الجزائر، المغرب، ليبيا اللي معناتها حاضرين معنا. نحب ايضا نشكر مخابر حكمة، شكر كبير على خاطر هما اللي ساهموا معنا في توفير هذا الفضاء، واللي اسمح لنا باش نتواصلوا مع بعضنا. قبل ما ندخلوا في الجد، كان ايضا تسمحوا لي باش نقدم شويه بسطه عن مختلف نشاطاتنا التكوينيه في كليه الطب بصفاقس. انا والفريق الطبي الاساتذه الجامعيه اللي معايا قاعدين ننظموا في دورات تكوينيه على تشريح العظم الصخري، على العظم الاصطناعي، خاطر العظم الانساني ممنوع عندنا في تونس. قاعدين ايضا نظمنا حاجه جديده في تونس وفي البلدان المجاوره، اللي هي المحاكاه الجراحيه بالمنظار. قعدنا نظمنا عده دورات، وان شاء الله تو قاعدين مواصلين، وان شاء الله تو نعلموا عليهم الدورات هذه، وان شاء الله تكونوا كلكم معنا في الدورات هذه. نحب ايضا نعلم على المؤتمر السنوي للجمعيه، اللي هو مش يكون زاده في ايام 5 و6 ماي 2023. ماي هكا، ماي سي رضا نقولوا ماي ولا مايو؟
مايو انجلش، ماي في المصري مايو.
مايو ولا ان شاء الله المؤتمر هذا مش يكون في توزر هي بلاد في الجنوب التونسي، بلاد مزيانه برشا، فيها صحراء، فيها برشا معناتها، فيها حاجات حلوه ان شاء الله، واكل مزيان، برنامج ايضا ثري، وان شاء الله الدعوه مفتوحه لكم الكل، وان شاء الله الدكتور رضا زاد يكون معنا ان شاء الله. باش تتابعونا اكثر وتابعوا نشاطاتنا، عندنا صفحه فيسبوك للجمعيه، جمعيه امامز ولا اميكال دي زواريل، وعندنا ايضا الصفحه الرسميه لكليه الطب في صفاقس. توا سامحوني إذا كان هكا عملت تقديم طويل شوية، إن شاء الله ما طوّلتش عليكم. باش نحيل الكلمة لصديقي اللي يشاركني في إدارة الحوار. الدكتور منصف السلامي هو أستاذ مبرز في نفس القسم بصفاقس، وهو أيضًا مختص في أمراض جراحة الجيوب الأنفية، مغروم ومختص في القسم بالأمراض هذية، وأيضًا هو نائب رئيس الجمعية. تفضل منصف، ومرحبا مرة أخرى، سعداء جدًا بالدكتور رضا كمال. تفضل منصف، تفضل دكتور.
شكرا جزيلا بروفيسور شرف الدين.
تكلم بالإنجليزي توا.
I will speak in English. Okay, good evening everybody. I start by welcoming our hosts, our special host, Professor Rida Kamel, and all the participants to this webinar. I will start by introducing our host, and I know that he is very well known and appreciated by our community. Professor Kamel is a professor of rhinology at Cairo University in Egypt. His main interest is endoscopic sinonasal surgery, allergy, and sleep studies. He published more than 20 articles. I read all the articles. They are very interesting. Articles about endoscopic sinonasal surgery, and a book titled Anatomy and the Lateral Nasal Wall, Osteomeat and Complex, and the Endoscopic Skull Base. Professor Kamel is actively involved in international congresses and dissection courses the whole world. He is constantly pushing the boundaries of rhinology and endoscopic nasal surgery in the Arab world, Africa, and around the world. He has a unique and a didactic approach to explaining sinus disease and his surgical techniques. We are pleased to have him with us tonight to talk about an interesting topic, functional endoscopic sinus surgery step by step. I invite our participants to please feel free to ask any question in the Q&R section, and we will discuss them with Professor Rida. Professor Rida, the floor is yours. فاكر كلمة سيدي.
في الحقيقة أتكلم الأول بالعربي، وأنا فاهم إن إحنا المحاضرة هتكون بالإنجليزي مش بالعربي. سليم كده؟
أي.
طيب بس نتكلم بالعربي الأول. أنا شكري شديد، شكر كبير. بشكر زملائي برشا كتير خالص إن أنا أكون معاكم النهاردة اليوم، وحقيقي فرصة كبيرة إن شاء الله نتشارك الخبرة الجميلة في مجال الأنف، جيوب أنفية، مناظير. وحقيقي نفسي كتير إن أنا يجي فرصة أكون موجود معاكم فيس تو فيس إن شاء الله. طبعا أساسا عشان أشوفكم وأطمن عليكم وناخدكم بالأحضان إن شاء الله. مش بس كده، وعشان الهم الأكل الجميل بتاعكم، والشوربة التونسي والكسكسي والطاجن والأكل الجميل إن شاء الله. وأنا متأكد إن كمان تونس جميلة خالص خالص، وجنوب تونس حلوة برشا إن شاء الله. فشكرا كتير جدا دكتورة إلهام شرف الدين. إحنا بنقول كده إلهام وشرف الدين. على فكرة إلهام وشرف الدين very common names عندنا في ايجيبت. فشكرا جدا دكتوره الهام على الدعوه الجميله اللطيفه الظريفه العفيفه الشريفه ان اكون انا معاكم حقيقي. يعني شكرا كتير خالص. شكرا ليك. ودكتور بقى منصف سلامي، الاسمين صعبين يعني قليلين عندنا، لكن طبعا اسمين جمال، لطاف، ظراف، عفاف، وشرف. وانا حقيقي شكرا جدا ليك لتعبك معايا، وان احنا ننظم اللقاء والاتصالات المستمره والتنظيم والتذكير، ميمو اند ريميمو اجين. فشكرا كتير ليكم، واتمنى ان شاء الله تكون محاضره حلوه، واتمنى انقل خبره جميله، لان فعلا it's very important to perform functional endoscopic surgery in an effective and safe way. فاسمحوا لي ابتدي ان شاء الله بعد اذنكم.
تفضل.
To state its function in endoscopic sinus surgery, I just want to tell you that this is our work at Cairo University, and I'm inviting you, everybody, to visit between Tunis and Egypt, Cairo. We say فركة كعب أو خطوة أو خطوتين. I don't know exactly how to say it in Tunisian, but it's too near, and you can just go to the airplane and welcome to Cairo and Egypt. Step by step understanding of the basic function in endoscopic sinus surgery. To begin with, we understand that endoscopic sinus surgery begins by unsinectomy, then we proceed to middle meatal antrostomy, and then we may proceed to anterior ethmoidectomy. I just want to state it that this is the green zone. The green zone, or the anterior compartment. I would like to say that this area is relatively easy to perform and relatively safe during performance. That's to say, it's for anybody who is going to begin performing unsinectomy, middle meatal antrostomy, and anterior ethmoidectomy may look easy, but at the same time, be careful. The possibility of complications is there. Then we proceed to the yellow zone, the basal lamella opening. When we proceed from the anterior ethmoid to the posterior ethmoid, we open the basal lamella and then proceed to the posterior ethmoid and then slip into the sphenoid. This is the yellow zone where the procedure is relatively more difficult than the green zone, the anterior compartment, but less difficult than the orange zone. And at the same time, the complications are more than the green zone possibility. Then we can proceed to the superior compartment, the skull base clearance. We finish the anterior compartment, answer middle meatal antrostomy, and the anterior ethmoid. Then we open the basal lamella and proceed to the posterior ethmoid and the sphenoid. Then we go from posterior to anterior to proceed into the frontal recess, the orange zone. And then we stated, avoid the complication. Don't bypass the boundaries, the sinonasal framework. Don't bypass the skull base into the brain, big problem, complication. Don't bypass the lamina papyracea into the orbit, complication. So usually we can perform the green zone, then the yellow zone, and proceed the orange zone, avoiding the red zone or the complications. So let us proceed to the procedure. So now we are on the right side, and as you can notice here, the nasal septum, the arrow is clear. The arrow is clear. The nasal septum.
Yes, we see it.
The nasal septum, the middle turbid, the lateral nasal wall, inferior turbid, and middle turbid. And depth up there, we can depict or anticipate the quina. So anatomy, we begin by identification of the nasal septum, the middle turbid, the inferior turbid, lateral nasal wall, the middle meatus, superior meatus, the middle meatus between the middle turbid and the inferior turbid, the superior meatus between the middle turbid and the nasal septum, up there towards the superior turbid. Just a slight tilt of the middle turbid exposes the osteomeatal complex. And now we are on the right side again. We can identify easily the onset process, and maxillary line. Just behind the onset process, we can visualize the bulla. The bulla ethmoidalis, just up there. The osteomeatal complex. We understand between the onset process and bulla, we have here the hiatus seminaris inferior. And then behind the bulla, and between the bulla and the basal lamella and the middle turbid up there, we have the hiatus seminaris superior. Then we can proceed again, more tilt of the middle turbid, exposure more and more of the osteomeatal complex, exposing the onset process laterally along the maxillary line and exposing the bulla ethmoidalis. anatomy. And then whenever we just introduce our curved tool, the maxillary seeker, between the onset process and the bulla ismodalis, we can identify the hiatus seminaris inferior and the infundibulum. The infundibulum is the space between the onset process and the bulla ismodalis. The hiatus seminaris is the door between the onset process and bulla. So the hiatus seminaris inferior is nothing but the door into the room, which is the infundibulum. So it's the anatomy, and anatomy again. Usually we begin by removal or taking care of the onset. We can utilize whatsoever a tool to take care of the onset. In most of my work, I usually use the dissector or sickle knife. We can use the backbiter, but the backbiter is relatively bulky, and in most of the cases, it's relatively dangerous. It may insult the lamina preparation. Whenever you are going to take care of the onset, you have to identify it beforehand and identify the hiatus seminaris inferior between the onset process and bulla ismodalis. And according to what we did here, we created nothing but a window. This window leads you into the infundibulum, and this window through which we can identify the bulla ismodalis. And if we increase this incision, extended it inferiorly and superiorly, now we can visualize clearly the infundibulum, and we can identify the bulla ismodalis. Then we can remove the onset. Usually we utilize the through cutting forceps to cut the upper edge of the onset process and the lower edge of the onset process and remove the onset process. Mind you, be careful. Don't remove too much or more than the onset at the hinge. Why? Because if you inserted this frontal process of the maxilla, you will induce bleeding. If you left a big part of the onset, it will hide the pathology just behind. So accordingly, we can take off the onset process out. After removal of the onset process, now we can identify the bulla ismodalis clearly within the osteomeatal complex. Now again, right side, the middle termit, especially the vertical part or the first part, then the bulla ismodalis, then the site of attachment of the onset process. Accordingly, we expect the maxillary sinus ostium at the bulla onset angle posterior and inferior. Here we are. And we expect the frontal sinus ostium up, and anterior up there. And accordingly, here we are. I just want to make sure the video is clear.
Yes, very clear.
Yes.
Perfect. So now again, it's the same. It's cadaver dissection for anatomical orientation, the neck of the middle termit, the lateral nasal wall, and the nasal septum. And what we are doing here, we are doing nothing. We are just tilting the middle termit. You see medially, the aim of work here is to expose the bulla. Now this is the first part of the middle termit, third part of the middle termit. And now we are proceeding just to demonstrate the anatomy. Now what we are doing here, we are proceeding to demonstrate, here we are, the anatomy. We can just show you here what this is the onset process, the bulla ismodalis, and the hiatus seminaris inferior, hiatus seminaris superior, between the basal lamella and bulla. Between the, here we are, the basal lamella, and here we are. We can proceed to the aim of work here is to demonstrate. Here we are. Before we remove anything, I just want to make sure here, this is the nasal septum. Again, we can proceed just to show you what we did in here gradually. That's it. Here what we did here. We proceeded and we identified. We can use the onset process. Here, this is the bulla, middle termit, bone, and then giving way. That's the beginning of creating a window you have to work parallel to the lamina papracia, not to insult the integrity. And then we can widen this into, here we are widening inferiorly, and superiorly. In most of the cases, we can remove only the lower 2/3 only. But here we are, we just want to show you how to proceed. Now we created a bigger window into, we can visualize the bulla ethmoidalis and the site of the maxillary sinus ostium at the bulla onset angle posterior and inferior. We are lucky, the anatomy here we are very clear. We can proceed superiorly if we are intending to visit the frontal recess. Here we are, this is a cadaver dissection just for the step by step. After taking this out here up there, we can proceed using, here we are, you see, this is the, and then we can proceed, taking care through cutting forceps. Hop, we cut the upper edge over the onset. And then now I just want to make sure the bulla ethmoidalis, and then we can take care of the lower part of the onset and take it out there. After that, we can expose the bulla ethmoidalis, the medial turbid, the onset process remnant, and maxillary sinus ostium. And that's what we usually do every day. Now this is the end, the bulla ethmoidalis, the remnant of the onset, the maxillary sinus ostium without touching it itself. So it's the anatomy, and the anatomy again. Identifying the maxillary sinus ostium, we do not widen the ostium in all the cases. We widen it only when there is a good indication. What we usually do is to utilize the true cutting forceps to widen the ostium posteriorly. Posteriorly is the safest, easiest, and the least functional affection. We don't widen the ostium anteriorly except if there is a good indication. And we widen it posteriorly. The aim of work here is to proceed. But we can widen it anteriorly. Here we are. This is a case of cadaver dissection. So accordingly, we can widen it anteriorly using the backbiter. Here we are. This is the backbiter. We open it, apply it, and then we cut it to widen the ostium. Widening the ostium anteriorly, be careful not to insert the nasolacrimal duct that may induce postoperative epiphora. And accordingly, now that the beginning of taking care of the bulla ethmoidalis, usually we begin inferior and medial, always inferior and medial. Why inferior and medial? Because if we begin superiorly, it's the skull base. If we begin laterally, this is the lamina papracia. We don't want to insult the skull base. We don't want to insult the lamina papracia. This is the anatomy, and the anatomy again. Now we proceed to take care of the anterior wall. We can utilize whatsoever a tool. We can use the grasping forceps, through cutting forceps, shaver. We can use the mushroom, garrison, and so on. Now we opened the anterior wall of the bulla ethmoidalis after removal of the onset, after widening of the ostium because of the indication. We tailor our surgery according to the pathology of the patient. So accordingly, what we usually do is to begin to taking care of the anterior wall. Now we are removing the floor of the bulla, and we can proceed. Here we are, the same case, and now we are opening the bulla, inferior and medial. Here we are, inferior and medial, beginning inferior and medial. And then after opening it, we can proceed. This is unedited, so I just want to show you perfectly. We are inside the bulla ethmoidalis. Now the maxillary sinus ostium is down here. Now the anterior wall of the bulla, the inferior wall of the bulla, the medial wall of the bulla, posterior wall of the bulla. So accordingly, we can proceed using whatsoever a tool. Now we are using the straight mushroom. We can use it, no problem. We can use other tools. We can use, here we are, the straight mushroom, taking care of this, just to show you how the bulla is a true bulla, Now I just want to make sure this is the basal lamella, the first part of the medial turbid, the second part, and we are introducing our curved tool just behind the bulla to demonstrate the retrobullar recess which is part of the lateral sinus. And now I'm showing the lateral wall of the bulla. The lateral wall of the bulla is nothing but the lamina papyracea. Be careful. We may remove the anterior wall of the bulla, the medial wall of the bulla, the inferior wall of the bulla, superior wall of the bulla, posterior wall of the bulla. Never and ever to remove the lateral wall of the bulla, which is nothing but here we are. Now we are taking care of the bulla and removing it. And I'm going to show you after that where we are. Now, after removal of the bulla, we can expose the basal lamella. Now, this is the first part of the medial termit, the sagittal part, and then the second part of the medial termit, the coronal part, and then the third part of the medial termit, the axial part. Accordingly, we understand that the basal lamella is adherent superiorly to the skull base, adherent laterally to the lamina papyracea, adherent medially to the first part of the medial termit, and adherent inferior to the third part of the medial termit. So this is the basal lamella. The first part, sagittal. The second part, corona. The third part, axia. First part, second part, third part. So whenever you want to proceed from the anterior ethmoid after removal of the bulla ethmoidalis into the posterior ethmoid, we have to go. Are we going to go superiorly? Never. Are we going to pass laterally? Ever. Always inferior and medial. Why? Inferior and medial, it is the safest and thinnest as well. So here we are. We usually proceed along the sagittal part and then hop, we are coronal. And proceed along the axial part and then hop, we are coronal. The meeting point is where we begin to open, and that's it, the beginning of opening. Avoid insulting the third part. Avoid insulting the first part. Avoid going far lateral to the orbit. Avoid going far superiorly into the skull base. And now what we did here, we just created an opening into the basal lamella to proceed into the posterior ethmoid. So now what we usually do is to widen this opening superiorly and laterally. Superiorly and laterally. How to widen it superior and laterally using whatsoever a tool. The best tools use the straight mushroom. We can use the kerrison. We can use the shaver and so on. What we are doing here is to proceed from the anterior ethmoid into the posterior ethmoid. If you are going to proceed into the posterior ethmoid, one of the most important landmarks is the superior termit. The superior termit, we go along the medial termit and then create the gutter in between the medial termit and superior termit. And now we are introducing our tool between the superior termit and medial termit into the sphenoid ethmoidal recess, into the sphenoid sinus. So accordingly, what we usually do is to identify the superior termit. Being able to identify the superior termit will give you an excellent chance to clear the posterior ethmoid. We understand the anterior ethmoid air cells are too many but small in size. The posterior ethmoid air cells are few in number but big in size. And usually we can widen them and take care of them using the shaver, maybe polyps, pus, fungal debris, through cutting forces, and so on. And after you see here, now we identify the superior termit. Then began to clear the posterior ethmoid. And then we could clear the corner up there. We are on the right side. So now we can identify this corner where we may have an onodi cell. Now we can understand this is a corner. Up there, the white color of the skull base in cadaver dissection and even in patient. The yellow color of the orbital apex and lamina papyracea. And then the bulge or pink or blue color of the sphenoid sinus. Very important to go up there. Very important to clear this area. Very important to avoid an insult to the skull base and or to the lamina papyracea. Unfortunately, the lamina papyracea here is nothing but in the orbital apex. The optic nerve is here, too near. And this is the way into the cranial cavity. Now, it's the same case Now this is the middle termit, and then antiprocesses are already been removed, and then we are proceeding. We are proceeding into, this is the third part of the middle termit shown. The first part of the middle termit, the basal lamella. And now what we usually do is to proceed along the axial part, hop, corona. Sagittal part, hop, corona. Avoid lateral opening, the lamina. Avoid superior opening, skull base. And now we are proceeding inferior and medial. We are proceeding inferior and medial. You see, that's it. The first opening should be in here. Be careful. Don't insert the third part. Don't insert the sagittal part. Open the coronal part into the posterior ethmoid. That's it. So it's the anatomy. Now we introduce our tool. From there we can widen it superiorly and laterally. What's the best tool? We can use the mushroom. Here we are. The mushroom will widen laterally and superiorly. Laterally and superiorly. Widening laterally and superiorly. Now we are able to visualize the posterior ethmoid. Now, next step, this is the third part of the middle termit. This is the first part of the middle termit. So now we can proceed to identify and look for. Here we are, this is the third part, and here we are to look for. Excellent. This is the superior termit, the gutter, the sphenoethmoidal recess, and in the depth, we can identify the sphenoid sinus ostium. It's the anatomy, and the anatomy again. Identifying the superior termit will give you a very good chance to proceed into the posterior ethmoid and clear it. Clearing the posterior ethmoid, we can proceed up there. We proceed and take care of the posterior ethmoid air cells. We take care of the posterior ethmoid air cell to be able to, here we are, the corner, the skull base, the lamina pressure, the bulge over the sphenoid. And here we are, after being able, that's it. Here we are, that's it. Here, the skull base superiorly. The lamina, yellow, lateral. The bulge, the pink or blue color of the sphenoid. The superior termit, sphenoethmoidal recess, middle termit, the sagittal part, middle termit, the third part. So it's the anatomy, and the anatomy again. And after proceeding, we can proceed, and then we can proceed into the sphenoid. Going into the sphenoid will give you a very good chance to go into the sphenoid sinus up there. So the anatomy. Now, just tilting the superior termit will give you excellent view into the sphenoethmoidal recess, into the sphenoid sinus ostium. Here we are. This is the ostium. And then here we are. This is the corner, and this is the anterior wall of the sphenoid. Now, one should be aware of the superior termit. Accordingly, we can open this. Are we going to open superiorly? Never. Open lateral, ever. Superior is the skull base, and lateral is the orbital apex. So, now we can proceed. Opening the sphenoid sinus. If we are confronted with an axial septum like this, we have to revise the CT. In most of the cases, this will demonstrate an onodi cell. The septum is hiding the sphenoid sinus below, and the onodi cell up there you see here. And the optic nerve in such a case is within the onodi cell. And this is the sphenoid sinus. We have to anticipate this beforehand, before surgery. The CT should be there. Never ever to perform endoscopic sinus surgery without the CT. Otherwise, you will go to jail. I don't know exactly how is the jail in Tunisia, but you have to avoid going to the jail because of the malpractice. So you have to perform your surgery effectively and safely. You have a jail up there, or you don't have a jail?
Yes, we have.
You have, sure, everywhere. So we have to be very careful. And now we can identify the optic nerve is up there. The carotid artery is down here, and in between the optico-carotid recess, in between with the planum up there, like livus, sella, tuberculum celli within the sphenoid sinus. After we have to be careful not to insult the optic. We have to be careful not to insult the carotid artery. And here we are. This is the situation where we begin to, that's the skull base. This is the sphenoid sinus, ostium. And then this is the medial terminal. We can identify the ostium just to be aware. The quana is down here. And then we can go along here with the quana and the oscillating tube, fossa of muller, roof of the nasopharynx, face of the sphenoid, and then hop, we are inside the sphenoid sinus. We have to identify the sphenoid sinus. This is the superior terminal. For orientation, this is anatomical orientation, and this is the posterior ethmoid, and this is the superior terminal. And now we are just exposing this area, and we realize that we have here, this is the superior terminal, and now we realize that we have here the sphenoid sinus is down here, and the onodi cell is up there. Here, and the optic nerve is very clear within the onodi cell, not within the sphenoid sinus. It is the same situation. Be careful and insert to the optic. Be careful and insert to the carotid. And here we are. We can proceed performing the very good. Here we are. This is the way. Now, I would like to show you that after that we can proceeding into the skull base. The skull base, here we are, towards the frontal recess. We remove the air cell along the roof. This is the next step where we can proceed. Now we have to be able, that's posterior, anterior, mid-terminate, lamina brachia, sphenoid, posterior ethmoid, anterior ethmoid, and the area of the frontal recess. Now we begin to proceed from posterior, anterior, and then proceeding. Now we understand this, the fovea ethmoidalis, and then proceeding into the frontal recess, anterior, we go into the frontal recess. In most of the cases, we don't touch the integrity of the frontal sinus ostia to avoid neo-osteogenesis and reclosure of the sinus. Fovea ethmoidalis, anterior ethmoid artery, be careful, which is the direction with the anterior ethmoid arteries angle from lateral to medial, from posterior to anterior. And then we understand supraorbital ethmoid cell anterior to the anterior ethmoid artery, the frontal recess ostium. In most of the cases, we stop up there. We do not insult the integrity of the frontal sinus. For the maxillary sinus, it's relatively easy to widen the ostium. Why? Because we have mucous membrane all around because of the fontanelle area. It's very hard to widen the frontal sinus ostium. Why? Because we have bone around all through. So it's very difficult and hard to widen. And we don't widen the ostium of the frontal sinus except if it is highly indicated. And now, in most of the cases, the anterior ethmoid artery, supraorbital, frontal recess, and the frontal sinus ostium. One of the very interesting tricks is to apply light up there. Here we are, supraorbital, frontal recess, frontal ostium, anterior ethmoid artery. So it's the anatomy. And what we usually do is to do a very interesting transillumination along the anterior wall of the frontal sinus, and according we can appreciate the light from below. In most of the cases, we may be obliged to clear the agar cell. This is the neck of the medial terminate, then the medial terminate proper. This is the remnant of the onset, and the agar is just behind. So if there is a good indication to clear the agar, well and good. If there is no good indication, don't touch it. Don't go up there. Don't visit this area, because a big possibility to induce iatrogenic itis and or piocele or mucocele. And then we go into the frontal recess to identify the frontal sinus ostium. Nothing else. We suck secretions from inside, draft type 1. And then we can apply the light from outside. And here we are, you see here, this is the light applied from here. Be careful not to burn the skin. Otherwise, you will go to jail. Be careful. We don't want you to go to jail. And here we are. The jail is Sign, prison. You do like this for the prison. Here we are. And accordingly, now I just want to show you. We did what we did. We did the anterior compartment, unsaid bulla, millimeter antrostomy. We did the posterior compartment, basal lamella, posterior ethmoid, and sphenoid. And then we did the superior compartment, the skull base, frontal recess, and the frontal sinus osseum. And stop, hop, stop. Now be careful. Why? Because if you bypass the sinonasal framework, you may induce complication. I just want to show you one of these complications. Here we are. We are utilizing the navigation to demonstrate you how we can proceed into the orbit. Now, hop. You can appreciate the tool into the orbit, into the optic nerve and the globe. Be careful. We have to stop at the lamina papyracea. We have to stop because here we are, you see here, what we did here. Now we are proceeding. We have to understand where to stop before we get into the orbit and it is too late. Now, skull base. I just want to show you this. This is again cadaver dissection to demonstrate to you the aim of work here. This is the cribriform plate, the fovea ethmoidalis. We may go, here we are. I just want to make sure that, what happened here? We are inside via the fovea ethmoidalis into the brain, into the brain. This is mentioned to be condemned. I just want to reach the conclusion. Step-by-step performance of functional endoscopic sinus surgery is mandatory to handle all cases of chronic rhinosinusitis with or without nasal polyps, fungal rhinosinusitis effectively and safely without complications, without going to jail. I just want to say it again. Conclusion. The green zone, anterior compartment, unthread, middle meta-antrostomy, anterior ethmoidectomy. Yellow zone, basal lamella opening, posterior ethmoid, sphenoidotomy. The orange zone, skull base clearance, frontal recess clearance, to stop the superior compartment. And then the red zone, the jail, we have to avoid it, which is the red zone. Then I just want to make sure that everybody is having a copy of this. Anybody who does not have a copy of this, just go to my website and download it, or I will send it to Professor Ilham and Professor Monsef a digital copy of this book, which is very basic and very interesting for everybody to begin the functional endoscopic sinus surgery, or you can collect it from the Stoll's company free of charge. I just want to invite everybody to be part of the Pan-Arab Rhinology Society. It will be a very good chance to be part of this, and looking forward that, inshallah, in near future, that you will arrange the coming PARS. Last year, the PARS meeting was in Jordan. This year, it will be in Iraq, and hopefully next year, maybe in Tunisia. No problem. And you are invited to come to Iraq as well, but we will go to Egypt at first. Now, again, I invite everybody to send his or her publication, Rhinology, to the Pan-Arab Journal of Rhinology, the page, Pan-Arab Journal of Rhinology. I will send again the link of the website, and in fact, it is part of inline, and it is double blinded journal, so it's very good chance to publish your journal or publication in this distinguished journal. And then I invite everybody to join today Rhino Egypt ORL group. and it's a good group, and we share our experience together. Definitely, I would like to invite you all to come to Egypt next March, nothing but شهر ونص إن شاء الله, to join us at Rhino Egypt 29. This is the 29th of Rhino Egypt. We began in exactly in 1995. The same birth of your distinguished society. It was the same day or the same month or the same year where we began our Rhino Egypt activity in Cairo. It was the first one in 1995, and this year it is the 29th. Thanks God, alhamdulillah. March 2nd, 2-4 March, inshallah, rhinoegypt.org. You can go to rhinoegypt.org for all details. At the end, I just want to state it. Usually we say that knowledge is power, and together we can make a big difference. We can help each other, take care of each other, and definitely visit, inshallah, each other. Hopefully, the lecture was Latifa, ظريفة, عفيفة, and شريفة, وتكون حلوة خالص, أو جميلة خالص, أو لطيفة خالص, أو تكون شريفة برشا, أو حلوة برشا. وأنا حبيتكم خالص, حبيتكم كتير, حبيتكم برشا إن شاء الله. ولooking forward بإذن الله للقاء قريب يكون إن شاء الله physical face to face, عشان ناخدكم بالأحضان ويكون كل حاجة جميلة إن شاء الله. ولو في أي أسئلة أو حاجة أقدر إن أنا أرد عليها, هبقى very happy إن شاء الله.
منصف.
Thank you,
يعطيك
Professor.
الصحة دكتور.
أنا معاكم, ولو في أي أسئلة أتمنى يكون في تعليق حلو على المحاضرة إن شاء الله.
Bravo, Professor. أحسنت. Thank you for this excellent presentation. It was very interesting, and we have many questions in the chat, and we'll discuss them with you. So the first question, what's your it's a question, what's your preferred way to prepare patients for first surgery? It's a question about medication.
Medication before or after?
Before surgery. How do you prepare
before surgery?
for surgery?
Yes, before surgery we do our best to avoid surgery at first. We usually take care of our patient according whether the patient is CRS with nasal polyps, CRS without nasal polyps, especially allergic fungal rhinosinusitis. These are the most common cases we do for FAS. So usually we take care of these patients with the local steroid, with the saline, sometimes with antibiotic, sometimes with systemic steroid. This is the main core of our work. We can resort to all other medication to help the patient avoiding surgery. And we don't perform CT except after failure of medical therapy. And we don't proceed to surgery except if we failed the medical therapy. If we plan surgery, we can just keep the patient on local steroid and the saline irrigation, and prepare the patient for surgery, and then we can depend on the post-operative medical therapy as well. And we understand that surgery is not the cure, surgery is not the end, surgery is part of the help of the patient. So usually we warn the patient of failing the proper compliance for the post-operative medical surgery and endoscopic care.
How did you proceed when the middle middle turbinate is hyperthyroid. Do you proceed to the section or how?
So this is a very, very interesting and very important question. Truly, what we usually advise is to avoid any insult to the mid-determinant. The mid-determinant should be kept integrity. The first part should be very clear. The third part very clear. You open only the middle part and proceed. But just in case if the mid-determinant is already flail or the mid-determinant is already included by the pathology, or you are unlucky because of surgery, we insult the integrity of the mid-determinant. Some advise vulgarization, some advise stitching, but it seems it's not a good option because it affects dramatically the smell. So what we usually do, if the mid-determinant is already flared or disease or finished, so we have to take care of it and sacrifice it. But in most of our cases, we do not sacrifice the mid-determinant, except if there is a very good indication.
Thank you.
Thank you.
There is a question from Dr. Ahmed from Libya.
Yes, please.
In case of traumatizing of lamina papyracea and exposing to post-periorbital fat, what surgeon should do?
Very good question. Thank you very much, Dr. Ahmed, because this is a common happening. Nobody is immune. When you are going to perform FES, you will face definitely cases of fat prolapse during endoscopic sinus surgery with an insult to the lamina papyracea. So don't panic. It's a common happen, but definitely try to do your best to avoid this insult. But just in case, if it happened, no shame and no problem whatsoever. But you have to continue surgery. What we usually do is to usually use the Sienkiewicz sign to make sure of the fat. You press on the globe and you see the fat moving. So this is fat. Don't wait to take the fat and put it in water. Floating, it's fat. No floating, it's mucous membrane. This is too late. Definitely the color of the glistening, the Sienkiewicz sign, this is fat. So stop. Don't try to recede it. Don't try to pull it. Don't try to shave it. What we usually do is if the prolapse is minimal, you can continue your surgery. If the prolapse is annoying you, you can just cauterize the fat slightly. Don't proceed into, don't bypass the lamina papyracea, don't bypass the periorbital. Just prolapse cauterize the prolapsed fat slightly and stop and continue your surgery. If you felt uncomfortable or you felt unconfident of proceeding, stop, don't proceed. If you felt you are misled or you got lost and you don't know your landmarks, no shame, stop and ask help of your colleague or postpone surgery for another session. Any other question?
Yes, there is other questions. A question from Mohammed Nizar. How do you manage the bleeding?
The bleeding. This is again very practical question. So bleeding, usually we have to make sure that the patient is not taking any anticoagulant. The patient is not on aspirin before surgery. We rehabilitate the patient. We give the patient saline and the local steroid for a while before surgery. If there is an acute infection, we have to handle the acute infection beforehand. If there is hyperactivity or allergy, we have to handle the allergy and hyperactivity beforehand, before surgery. But if we proceeded to surgery and we are confronted with bleeding, the irrigation is a very good option. We irrigate with saline. Don't get out your endoscope, out in. You keep it in and irrigate. Shh, shh, shh. The suction is down there. You can use your two hands and the suction is there. Your assistant, your nurse is irrigating. So the irrigation is very good. You may utilize the bipolar cauterization when indicated. You can apply vasoconstrictor, pledge it, no problem, no problem. This is in most of the cases. In most of the cases, the bleeding is ooze. Hardly ever we have a true bleeding from the sphenopalatine artery. Easy, we can cauterize it. The bad situation if the bleeding from the anterior ethmoid artery, even the anterior ethmoid artery, cauterize it. Don't allow it to retract into the orbit. So hardly, usually the anterior ethmoid artery, you have to anticipate it. You have to have a proper look at the CT beforehand, before surgery, to be able to anticipate where it is during surgery. Inside to the carotid, this is another mess. This is going to jail. So avoid the carotid artery.
Okay. There is a question. Please, can you give us your experience regarding infiltration? What concentration and way of for decreased bleeding during procedure?
The vasoconstrictor?
Your experience regarding infiltration.
Regarding what?
Infiltration. Mansouf, tu peux intervenir.
Ah, j'ai pas trouvé la question.
The question again, the experience regarding what?
Xylocaine infiltration.
Infiltration of mucosa.
Infiltration of the mucosa. Infiltration. I understand. You see. In fact, I have to confess that I don't use infiltration in most of the cases. But if I'm going to use infiltration, I usually use xylocaine adrenaline. I don't use adrenaline alone. Saline adrenaline, usually saline adrenaline 1 in 100,000. In 100,000. And we usually utilize 2.5 centimeters of xylocaine, 2.5 centimeters of adrenaline 1 in 100,000. So in general, it is 1 in 200,000. Usually, we avoid infiltration because the infiltration may induce any arrhythmia or so on. We utilize the local pledges with adrenaline. We can utilize adrenaline sec 1 in 1,000. If there is no contraindication, the patient is not hypertensive, is not cardiac, and so on. So usually I advise avoid infiltration because it's relatively dangerous. And if you did it, usually with xylocaine, so just in case if it is absorbed, it will protect the heart. So my advice is to avoid infiltration and use the local topical vasoconstrictor adrenaline as well with sec 1 in 1,000 if there is no contraindication. This will help a lot.
Thank you. We have another question from Professor McNasha. He's the secretary of our association. Do you clean and remove frontal recess in nasal polyposis surgery?
Whenever we have polyps at the frontal recess area, that's the question. This is a very interesting question. So we have to confess, we cannot remove the polyps 100%. We remove the polyps safely and effectively, and we understand that we depend on post-operative medical therapy. So at the frontal recess, whenever it is a de novo case, primary case, no previous surgery, we are lucky. Why we are lucky? We can take care of the answer process. We keep the integrity of the middle termit. We look at the roof of the ethmoid. We identify the anterior ethmoid artery and take care of the polyps at the frontal recess. We can use the shaver. We can use the grasping forceps, the true cutting forceps, whatsoever of tool. But whenever you are working at the frontal recess, be careful not to insert the skull base, not to insert the lamina papyracea, not to insert the anterior ethmoid artery. The aim of working at the frontal recess is to be able to go into the frontal sinus ostium. And again, I don't want to say 100%, but 99.9% of our cases, we avoid an insert to the frontal sinus ostium. In fact, most of the frontal sinus surgery, most cases are secondary cases because of primary surgery. And when you revise your CT before surgery, before the primary surgery, the frontal sinus was free. There was no good reason at all to visit the frontal recess area. So whenever we have polyps at the frontal recess, we can take care of the polyps. Again, don't insult the integrity of the mucosa of the frontal recess and or the frontal sinus osseum. If you have even polyps within the frontal sinus, you can suck these polyps. You can remove these polyps via the ostium. If you are obliged to widen the ostium to draft type 2A, 2B, this is another story, and hardly ever will proceed to draft type 3.
Thank you. All the participants, thank you. And before the questions, the question from Dr. Ines Harat from Tunisia. On polyposis, for example, how do you, are you sure to be aware of opening the basal lamella? We are in front of polyposis with inflammation.
This is very interesting case. I believe, inshallah, we can have another chance to go into the anatomy, and the anatomy again, and to define exactly. The basal lamella is a very important landmark. The basal lamella is very important pathway into the posterior ethmoid. So it's the anatomy. You have to be aware of the three parts of the medial term: the sagittal part, the coronal part, and the axial part. So whenever we identify the sagittal part, is very clear. And then we proceed from the sagittal part into the coronal. We revise matters from the axial part into the coronal. So the meeting point is the site, the safest and the thinnest part where we proceed into the posterior ethmoid. We understand in some cases we have a natural ethmoid cavity, definitely in recurrent cases, and sometimes even in primary cases, the laminar paprecia is rarefied. Again, the basal lamella may be rarefied, or maybe some air cells from the anterior ethmoid visiting the posterior ethmoid, or vice versa, from the posterior ethmoid into the anterior ethmoid. If you have the navigation system, this definitely will help you. If you don't have it, no problem. It's the anatomy, and always inferior, always medial. Identify the superior, the sagittal part of the medial termit, identify the axial part of the medial termit. Identifying these two structures will lead you to properly localize the expected site with the basal lamella.
Thank you. We have time to have discuss other questions, Professor Lila.
Sure. Gladly.
Okay.
You are on Thursday, and I'm very happy because most of these questions are very, very interesting and very informative. And I'm very happy of the interest of the participants and their share in questions. And maybe the questions are more interesting and more important than the lecture itself.
We have colleagues from Iraq, but thank you for the presentation from Iraq. We have another question from Professor Dr. Morsi. Do you usually prefer the FEAR elevator or a second knife for uncinectomy?
Usually we say it even the best way is the way you are mastering. A lot of advice in my work. Usually I use the dissector, thread dissector. Why? The second knife is very sharp, and the second knife is angled, so you may misdirect it into the laminar paprecia. The dissector usually after using the maxillary seeker to be able to identify the onset process. In such a case, you can begin using the dissector. However, some advise using the backbiter. Using the backbiter is a good tool. It's okay, no problem. But in many cases, you may insert the laminar paprecia, especially for a beginner. If you are planning to utilize the backbiter, it should be after being able to do it many times with the second knife, with the dissector, and so on. But don't go first time to the backbiter. Backbiter is relatively bigger, and those who are advising using the backbiter, they advise the very tiny small size of pediatric. It's not available everywhere. You don't have many backbiters to have the pediatric type, then type size 1, 2, 3. Usually you have only one of the adult size. So be careful. The dissector is okay. The second knife is okay. The backbiter is okay. So the best tool you are going to utilize is the best tool in your hands.
Mm-hmm. Okay. We have another question from Dr. Harat. The best way to dissect the skull base to locate it in the posterior ethmoid and to go anteriorly. So you go from the posterior to the anterior usually.
Exactly. That's true. Thank you very much for the question. Exactly. So usually we proceed inferior from the onset to the bulla, to the posterior ethmoid, to the sphenoid, and then we go to the best way to go into the posterior ethmoid is to identify the planum. The planum is very good way to proceed from the planum into the posterior ethmoid, into the anterior ethmoid. Be careful. The CT should be there, and be aware of the sagittal cut. And if you are lucky and you have the CD and you are utilizing whatsoever a triplanar computer program to show you the sagittal, the coronal, and the axial cuts at the same time, now you are relatively, I don't want to say safe completely, but now you can anticipate where is the planum, where is the fovea of the posterior ethmoid, where is the fovea of the anterior, where is the frontal recess area. So you can proceed step by step from posterior planum, posterior ethmoid, anterior ethmoid, fovea ethmoidalis, frontal recess, and the frontal sinus ostium. The color, white color, the yellow color of the orbit, the white color of the skull base, the feeling of the skull base. I don't want to say it's hard, but it's definitely not as thin as the lamina, not as thin as the mid-determinate.
There is a question from our friend, Dr. Yazid. In what situations that you should practice radical ethmoidectomy?
Again, the question, please.
In what situations that you should practice radical ethmoidectomy?
Radical ethmoidectomy. Usually, I don't want to say it always. This is a political question. Political question. I mean, I don't want to say it's a difficult question, but usually it is. What's your trend? My trend is basically conservative, then conservative, then conservative, and then conservative, and then conservative again. I don't proceed to radical ethmoidectomy or radical surgery and the reboot and mid-determinate and the nasalization. All these nomenclature are, I don't want to say against the physiology, but some advise I don't proceed to this procedure except, and in fact, I have to confess, I have never done it before to remove all the mucosa, to expose all the bone, and to cut the mid-determinate, and to perform a wide mega anthrostomies, and perform draft type 3. So the full house and extended and radical ethmoidectomy, some advise it in recurrent sinonasal polyps with extensive pathology, recurrent sinonasal polyps after multiple surgeries. Some advise it after failure of medical therapy. Some pave the way for the biologics. So I believe that the natural mucosa is very precious. We have clues of reboot. Whenever you remove the mucosa, new mucosa appear. But again, we have other evidence. Whenever we remove the natural mucosa, it is replaced by neo-osteogenesis, and it's replaced by fibrosis. The mucociliary clearance is badly insulted. So the indication for extended, the indication for radical ethmoidectomy or radical surgery, very, very minimal, and we have to be very cautious performing such type of surgery. I'm sorry to say that.
Professor, I have a question. When
Please.
you are in the unity cell or posterior ethmoid cell, we saw that you open the anterior sphenoid to open sphenoid. Sometimes you go to sphenoid from the onody with the black sleeve 45 black sleeve. We go directly from the onody to the sphenoid. We do it.
Thank you again very much for this question, but we have to state that we don't visit the sphenoid sinus except if there is indication. If the sphenoid is involved by the pathology as well, extended, we proceed for sphenoethmoidectomy. If the sphenoid is not involved by a disease, we leave it in peace. If you are going to proceed to the sphenoid sinus, always try to identify the superior termit and then look for the sphenoid sinus ostium and identify the level of the face of the sphenoid. Now, you can proceed from the posterior ethmoid, whether it is onody or not onody, into the sphenoid sinus. Proceeding into the sphenoid sinus, always inferior and medial. But in most of the cases, we do not use the black sleeve at first, or even we don't use the straight suction at first. In most of the cases, we use the curved maxillary sinus seeker. Why? Because it's relatively blunt, the blunt side, and at the same time, it is curved. So we can direct as long as the CT is there, showing that the sphenoid sinus is there. So according, we can use it to make a whole face of the face of the sphenoid into the sphenoid. Mind you, the ostium is there, so we are aware where is the ostium, and we are opening the face of the sphenoid and communicating both together to clear the sphenoid sinus of the polyps, the mud, the mucin, the mucus, or whatsoever. Again, in most of the cases, we preserve the mucosa. We don't strip the mucosa. We don't remove the mucosa except if there is a very, 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 very good indication. We widen the ostium, aerate, drain, keep the mucosa healthy and in peace.
There are two questions about complication.
Please.
There is a question from Dr. Souha Khalil from Tunisia. In the event of a bone breach of the base of the skull during surgery, less than 1 centimeter, without leakage of cerebrospinal fluid, do you repair this breach or not?
This situation is we have to be very careful, because you see, we understand a fact. The dura of the anterior cranial fossa is not like the dura of the midcranial fossa and posterior cranial fossa. What do I mean? The dura of the anterior cranial fossa is very tiny and adherent, very tiny. And we learned that from our neurosurgery colleagues. Very tiny, very slim, and adherent to the bone. Whenever you insert the bone, hop, it is CSF leak. If you could not identify the leak, it's a leak. If you utilize a Valsalva maneuver, Valsalva, you ask the anesthetist to induce straining by the patient. So if the patient strained, the leak will appear and the washout sign will appear in most of the cases. So to say that you have 1 centimeter, it's a big defect. Usually we have that our defects should be very minimal, few millimeters. You have to stop, because if you insert was just 1 millimeter, 2 millimeters of the skull base, stop. The leak will be there. The washout sign, you have to don't proceed for 1 centimeter. Too much, it's big. For the ear surgery, you may even use the burr along the tegment tympani, and the dura is still healthy. But if you just touch the bone and think that it's just touch by whatsoever a tool to the dura, in most of the cases, it's a leak. So whenever there is a leak, never and ever to leave it. immediately apply an on-day graft, immediately on-day graft, because in most of the cases, 1, 2, 3 millimeters, 1 centimeter, too much, too big. It's too big. If it is 1 centimeter, sure that dura has already been inserted. Hopefully, you did not insert the brain itself, and so on, especially the shaver. Be careful using the shaver, because the shaver, it will suck the fat and or suck the brain and so be careful. Bone, in most of the cases in our work, it's a dural insult because it's tiny and very thin and adherent. So repair immediately. Don't wait.
Thank you. Another question from Dr. Khalil. In front of a well-developed ethmoid recess full of cells, how we can easily locate the frontal ostium if you have many cells?
The frontal sinus ostium, very good question. The frontal sinus ostium, again and again, the CT should be there, and the parasagittal cut is very important. The anteroposterior diameter, the frontal beak, how long is this? The anteroposterior diameter of the frontal sinus ostium, the relation to the anterior ethmoid. So what we usually do is to identify the important landmark. The neck of the medial termit, very important landmark. And then the remnant of the onset process, very important landmark. The anterior ethmoid artery, very important landmark. And then the agar cell. So what we usually do is, as I showed you, the neck of the medial termit, the onset process, the agar cell, just behind will go up there. Based on the CT, you can suck the secretion. You can apply light from outside, but be careful not to burn the skin. And you can appreciate the light from below. In most of the cases, you will be able to visualize the light from below, and that's definitely the frontal sinus ostium. Use blunt tools. Don't use the carrot. Use the curved suction, okay? The curved maxillary or frontal seeker, okay? To locate the frontal sinus ostium. Follow the polyps. Follow the mud. If it is allergic fungal rhinosinusitis, we are lucky in most of the cases. Why? Because in allergic fungal rhinosinusitis, the frontal sinus ostium is already widened by the fungal debris itself. The frontal sinus ostium is widened because of the expansile nature of the mud in most of the cases. Again, I warn you of trying to widen the ostium, except if there is a very good indication. In most of our cases where we have the polyps, the itis pus, the piocene, mucocene, and or fungal mud on mucine, there is no good indication. And unfortunately, many advise draft-free in all cases. If you perform a draft-free, the patient should keep under the care of doctors lifelong. And this is a big mess. And in most of the cases, draft-free, re-closure, and redoing draft-free is a big difficulty during surgery.
Thank you.
Any further questions?
There is a question. There is another question from Dr. Rizk from Libya. How to manage patients with orbital hematoma intraoperatively?
Orbital hematoma.
Hematoma.
Yes. If it is simple hematoma, external preseptal, this is simple, no problem. But if intraorbital bleeding with the proptosis, with the red eye, you have to rapidly interfere immediately, because 1 minute, 5 minutes count. And according immediately, one of the most important part of our courses, cadaver dissection courses, the lateral rhinotomy and the canthotomy here are lateral rhinotomy and inferior cantholysis. We cut the skin and then cut the ligament to relieve the pressure on the eye and rapidly ask for helped by the ophthalmologist, and you have to remove immediately the pack. I want to say that in most of our cases, we don't apply a pack at all after surgery. If you're performing a smart surgery, we don't apply any pack. We don't leave a pack. We don't use anything after surgery. The patient gets happy and the sinus is cleared immediately, and the post-operative care is minimal. But in some cases, we are obliged to put a pack, bleeding. So in such a situation, if there is an intraorbital bleeding, we have to stop immediately canthotomy, lateral canthotomy, inferior cantholysis, the removal of the pack, decompression. We begin to definitely ask for the ophthalmology help immediately.
Another question for Marwan Karemi. If we have rhinoplasty and face to do, which one first?
If we have septum, if we have septum, the deviated septum.
With the face, yes.
Yes, if we are going planning
yes.
You mean the septal deviation, and which side we are going to begin? Exactly. Usually, you advise that you begin in the right side. The right side, we remove the polyps and take care of the polyps. Or you mean rhinoplasty?
I think he mean rhinoplasty.
Rhinoplasty, usually in most of the cases, we don't advise rhinoplasty and endoscopic sinus surgery same. But I believe it depends on the person. In my work, definitely the aeration of the nose and the infection should be performed first. And after clearance of the infection, itis, polyps, fungal mud, and you are sure that the situation is okay, you can proceed to the rhinoplasty later. But performing rhinoplasty with infection inside, with fungal debris inside, with polyps inside, I don't do rhinoplasty myself. So, and I don't believe this is a safe procedure to be performed.
There is another question for Dr. Haidar Abdulrahman. What are the tips you provide for revision surgery?
For revision surgery, again, the CT, detailed CT, all planes, coronal, axial, sagittal, preoperative rehabilitation, local steroid, local saline irrigation, avoiding allergy flare-up, avoiding infection, acute infection, and so on to decrease bleeding. And then if there is good indication and seems very difficult, you have to ask for the navigation. And if the navigation is not available, you have to go to a place where the navigation is there, or you can refer the case for a navigation hospital. At the same time, it's the experience. It's the experience, because in revision cases, recurrent cases, anatomy may be distorted, anatomy may be not clear. But again, you have to go to the very, very strict landmarks. Usually you begin by the floor of the nose, the inferior termit, the floor of the maxillary, then the roof of the maxillary. You can go to the lamina papracia, and then to the skull base, proceed to the sphenoid, and then to the frontal recess. So usually the Quana, we keep awareness over the anatomical landmarks which are still available to follow, because the anatomy should be clear. If the anatomy is distorted, the navigation system may help. But again, awareness of the anatomy, because the navigation itself is not helpful alone without understanding the anatomy.
Thank you.
Any other question?
There is another question from Dr. Masmouti Mohammed. In the middle myototomy, up to where you will arrive posteriorly, and at the bottom to have satisfactory opening. What is the wide opening do you perform?
So how
The
big the
middle
opening is?
Yes, the limit of opening of middle myotomy.
For the middle metal antrostomy, we usually do small opening. Because you see in most of the cases, is it itis? Just pus. If the ostium is patent and nothing inside but pus, we don't widen the ostium. We suck the secretions. If what is inside is polyp, if we have polyps inside, we can widen the ostium. We usually say whether it is type 1, 2, or 3, but we can state it maybe 1 centimeter if it is itis, maybe 1.5 centimeter if it is polyps. That we usually widen the ostium. I don't want to say dramatically, but you see widen bigger whenever we have fungal debris inside. We want to offer better aeration, better clearance, better monitoring after surgery. We may perform partial medial maxillectomy. Partial medial maxillectomy, where we remove most of the medial wall, but preserve the inferior termit, preserve the nasolacrimal duct in recurrent allergic fungal rhinosinusitis. But definitely we may perform even medial maxillectomy total when we are taking care of inverted papilloma, especially inverted papilloma. So we can leave the inverted papilloma for another, inshallah, webinar, which is my cup of tea or my favorite. So
Thank
now
you very much.
we have two questions left.
Other questions?
We have a question from Dr. Khalil Soha. In proptosis of Graves, donc BASDO disease, do you approach the orbital endonasally, endoscopically, or what your landmarks? You do this surgery?
In which disease?
Graves disease. Graves.
In Graves disease. In Graves disease, usually. In Graves disease, usually we do not do that alone. Usually we work together with the ophthalmology team. The aim of work is to plan our surgery. We can decompress the orbit medially and inferiorly easily, utilizing our tools. But if there is a good indication for lateral orbitotomy, the ophthalmology team take care of this. But usually we do not work alone. Most of the cases, the decision is taken based on the co-work between our team and the ophthalmology team.
Very good.
Hopefully this is the answer.
Another question regarding the concabulosa. You don't operate it systematically when you do surgery.
In concabulosa, we have to take care of it. Why? Because in many cases, it is involved by a disease itself, pyocele, mucocele, or fungal mucine. So we have to evacuate it. Evacuating it, we have to regain the shape of the natural middle termit, the C shape. So if it is like this on the, say whatsoever aside, so usually we remove the lateral cap. We remove the lateral cap and keep the middle cap. So at the end, the lateral nasal wall and the middle termit with the nasal septum up there. Now we have free middle meatus for the aeration of the frontal, for the aeration of the maxillary sinus, and at the same time clearing any contents within the concabulosa. And it gives you a passage into the anterior ethmoid. It gives you a passage into the posterior ethmoid. But be careful not to insert the neck of the medial termit, and don't remove a big part of the medial cap of the medial termit to keep the integrity of the medial termit. Last question or more questions?
There is the last question.
Now we are going to pay for the coming questions.
Yes, the last question from Dr. Busafara. Hunaida, what about pre-medication? If you do, you prescribe steroids before surgery, oral steroids?
Usually, I don't prescribe steroid before surgery, except if I want to rehabilitate the disease and avoid surgery. But if the surgery is planned, so usually I proceed for surgery and I keep the steroid post-operative, especially in allergic fungal rhinosinusitis. And you understand that the guidelines, the international guidelines do not recommend steroid before or antibiotics before surgery. I would like to tell you that we have already finished our first part regarding the adapted Egyptian best practice guidelines, ear, nose, and throat, audio, vestibular, and phoniatrics. I'm going to send the book to Professor Ilham and to Professor Monsef. And at the same time, I'm going to send you the PDF of the first part of the ORLAP best practice guidelines, ECPG, ORLAP, the main book, and the summary. I'm sure it will be very helpful because we adapted the international guidelines to our community. Why to our community? Because they are different. They are different than Europe, or different than the States. So what we did, we did some sort of adaptation with a very, very meticulous methodology to put the rules or the guidelines how to handle different diseases: allergic rhinitis, acute rhinosinusitis, CRS with or without polyps, epistaxis, CSF. These are the topics in the rhinology, and we are in the process of finishing the second part, and we have our annual, exactly like annual meeting for Rhino Egypt. This year we will have our 6th ECPG or lab, and those who are going to attend Rhino Egypt, inshallah, will have a very good chance to come later for cadaver dissection courses, and will to come later for the ORLAP guideline course, inshallah.
يعطيك الصحة دكتور رضا كمال.
I believe
برشا. رجعنا للعربية، نشكرك برشا. صفقوا عليك، يعطيك الصحة. كان لقاء ثري جدا، كان مفيد جدا. سعدنا برشا بحضورك، استفدنا برشا من الخبرة نتاعك، بارك الله فيك على قبولك الدعوة نتاعنا. نشكر أيضا كل الأصدقاء والزملاء اللي حضروا معنا من مصر، من الجزائر، من العراق، من ليبيا. إن شاء الله يكونوا استفادوا، إن شاء الله نكونوا جاوبناهم على كل أسئلتهم، وإن شاء الله الكلكم تكونوا بحذانا إن شاء الله في توزر في 5 أو 6 مايو إن شاء الله في تونس. مرحبا بكم الكل.
أنا اللي بشكركم شكر كتير خالص، برشا شكر كتير، وإن شاء الله أنا looking forward للمستقبل إن إحنا إن شاء الله نلتقي بقى فيس تو فيس، إن شاء الله نكون في القاهرة قريبا، وإن شاء الله نكون معاكم في تونس إن شاء الله قريبا خالص. تسعدوا بالأكلة بتاعنا، المشاوي الجميلة والفسح الجميلة والهرم الجميل والنيل الجميل خالص والناس الجميلة خالص. وإن شاء الله إحنا نيجي نسعد معاكم بكل حاجة جميلة، بالصحاري الجميلة، بالساحل الجميل، بالأكل الجميل، بالكسكسي الجميل، بالناس الحلوة، برشا إن شاء الله. شكرا لك.
شكرا جزيلا.
مع السلامة.
شكرا لكل حضور.
باي باي.
شكرا بروفيسور.
باي باي إن شاء الله. شكرا لك. باي باي.
يعطيك الصحة يا منصور.
ميرسي. يعطيكم الصحة. ميرسي à tous. يعطيكم الصحة بسام و toute l'équipe.
ميرسي بسام، يعطيك الصحة. À la prochaine إن شاء الله.
à la prochaine. Bonne soirée.
Bonne soirée.
إن شاء الله.
على خير.